right, hey everybody, welcome to season 2, episode 3 of ZollCenter, Torsades de Points. Today we have a number of awesome expert panelists. I'm Katie. I'm a second year medical resident at BIDMC, and we have Dr. Susan McIlvaine on the call as well, a cardiology fellow and current internal medicine chief medical resident. And for our expert panelists, we have both Dr. Patricia Tung, cardiac electrophysiologist and associate director of electrophysiology fellowship program, and as well as Dr. Uzman Tahir, cardiologist and director of the cardiovascular genetic inherited arrhythmia, cardiomyopathy, and systemic disease center at BIDMC. So thank you so much for everybody for being here, and let's get started with our case. All right. So our case involves a 6-year-old female with a history of type 2 diabetes, prior breast cancer, status post chemotherapy, and bilateral mastectomy, interstitial cystitis with chronic dysuria, and nephrolithiasis, who presented for ongoing pain and nausea with a known right uretopelvic junction stone. Her course was complicated by Torsades de Pointes in the setting of multiple QTC prolonging medications. Patient actually presented to an outside hospital where she was given IV Zofran, an antiemetic, which resulted in an episode of sustained Torsades de Pointes that decompensated into ventricular fibrillation, requiring defibrillation. The patient was placed on an IV amiodarone drip, given IV magnesium, and transferred to BIDMC. And just of note that we'll talk about treatment options a little bit later in the case, but IV amiodarone is not typically something we would use to treat Torsades de Pointes. And likely the providers were worried about sustained monomorphic ventricular tachycardia at that point, which is why that was chosen. But it was subsequently stopped upon arrival, and we'll talk about treatment options in a bit. So I just wanted to highlight a couple pertinent parts of the history here. For this patient, she had a number of days of poor PO intake prior to admission, as well as ongoing pain, nausea, and some vomiting. And I also added in her medication list, and in bold, I highlighted the medications that have all been culprits of prolonging the QTC. So some of these I think we can see are, pretty common medications that you might think about in terms of some, antidepressant medications that might be culprits that we're aware of. But I also want to highlight these opioid pain medications like the oxycodone that she was taking, as well as OxyContin, which are really a dose-dependent QTC prolonging medication. Dr. Tung, I wanted to ask you, are there any common medications that you feel like house staff are, should be more aware of that are big culprits of prolonging the QTC? One for me is I didn't, think about too much that oxycodone is, completely a dose-dependent one. I thought about methadone, but I really didn't think about kind of all of the whole opioids as a class. Are there any other ones that you think that are good to highlight here so we can remember in the future?
I think, as you said, definitely the opioid pain medications, but things like antibiotics, of course, the fluoroquinolones, things like SSRIs that are commonly used. She's here, you have a tricyclic antidepressant listed. So I think those are probably the most common ones that come into practice. A lot of the really severe warning QT prolonging medications that I think are taught in medical school, some of those are actually not available on the market anymore. So these, I think, are the most common ones we encounter.
Yeah, and so this patient, was on a lot of these to begin with, and then, like you said, got a dose of the Zofran as well. So just something to keep in mind to sort of look at the med list before deciding to give that type of medication.
Mm-hmm.
Mm-hmm. Yeah, and exactly. And I feel like too, it's one of these additive effects as well for these medications. So if all these were on and then you add in another medication, like you said, like the Zofran, definitely be worried about it in the setting of probably some electrolyte disturbances too. Great. All right, so, this is not a totally mystery case. Obviously, I already said in the title, this is Torsades de Pointes. So I wanted to just briefly break it down a little bit. So, polymorphic ventricular tachycardia is actually more of an umbrella term. And within that, Torsades de Pointes is a type of polymorphic ventricular tachycardia. So in order to be, defined as a ventricular rhythm or ventricular tachycardia, the rhythm will have to be greater than 100 beats per minute or so, as well as they would have frequent variations in the QRS axis, morphology, or both. And then in order to really be defined of in Torsades de Pointes, it would be, first two things here, as well as an antecedent prolonged QT interval. And we often see for this, the heart rate's going much faster, the 160s to 250s. You often can have irregular RR intervals, as well as that cycling of the QRS, which is that twisting of the points that we see there. Right. So Dr. Tanya, I was hoping you'd be able to, kind of briefly review the cardiac action potential with us and, help us kind of understand how that's actually going to be a way that we can help understand, what treatment options work in this condition as well.
Sure. So just looking at your graphic here, if you look at the phase 0, or so depolarization of the cardiac myocytes, that's dependent on the rapid opening of sodium channels and sodium influx into the myocyte. So that happens very quickly. As you can see, the slope is very steep. And then pretty quickly thereafter, the sodium channels inactivate and you're starting at what you refer to as the plateau phase of repolarization. And there's 2 ion channels that are really critical during this phase. And you can think of this phase as kind of a balance between calcium ions going in and potassium ions going out, right? And so what that eventually does is those 2 actions together bring the cell back to the resting membrane potential, right? And complete the repolarization of the myocyte. So calcium, as we said, comes in early in phase 2 of repolarization. Potassium repolarization kind of stretches out over a longer period, and it depends on 2 types of channels. I'm sure Dr. Tahir will probably touch on this later on, but the 2 main actions are through the IKR, the rapid repolarizing potassium channel, and the slow or IKS channels. The vast majority of medications that prolong the QT through this effect act on the IKR channel. And so when you get to the end of that repolarization, the membrane potential is back down to resting, the calcium channels close, the potassium channels close, and then the process begins again for the next depolarization.
Awesome, thank you. Right. And so, using that, would you be able to walk us through kind of how torsade points start? And we'll go through kind of the steps here as well.
Sure. So I think, so you're showing here a very typical sequence of initiation of torsade de pointe, where there's a short, long, short sequence. And so why this is critical is that the refractory period in ventricular myocardium is dependent on the cycle length of the preceding beat. And so when you have a change in cycle length, like you show here with short, long, short, what it can do is change the relative refractory period of the myocardium in a particular cell. And then if you have kind of a premature impulse and depolarization, it can initiate local functional conduction block that sets up kind of the substrate for reentry.
Yeah, and I would say short, long, short was a term that I had heard a bunch in residency, but never really understood. And that's, in first year of cardiology fellowship, I heard it so much more, especially at EP conferences and things like that. So that's a helpful explanation of what that actually means, because that was, again, something that I had heard a bunch, but never really knew what it meant.
Yeah.
Harder thing to Google than like QT,
Right. The other thing to note, without sort of going into too much detail, is that when they've looked at animal models of how short, long, short set up, reentry, they find that if you look at what they call the repolarization gradient, so it's sort of looking at the actual repolarization between different types of myocardial cells, so the endocardium versus the epicardium versus the mid-myocardium, they see kind of a pronounced difference in repolarization amongst the different types of cells under these circumstances, which also contributes to kind of setting the stage for reentry.
Great, thank you for going through that. And here I just highlighted kind of going through the figure here, how it can be triggering you, like you said, set up that reentrant kind of circuit as well. And I believe this is kind of just, talking about that a little bit too. Do you want to highlight anything else on this slide as well?
Yeah, I would just say that, sort of when you think about what a reentrant circuit requires as sort of its basic ingredients, it requires, multiple pathways with different rates of conduction, right? So typically in this model that you're showing, you have one pathway with fast conduction and another pathway with slow conduction. And the way in this example reentry occurs is you have block in typically the pathway that conducts more rapidly. Then you have slow conduction down an alternate pathway. And then when it encounters kind of the point at which it joins, right? Because they have to be connected in some way too to form a circuit. And so when it encounters the tissue of the fast, rapidly conducting pathway, it's able to come around and go conduct in the other direction, if that makes sense, and then complete the circuit. Mm-hmm. And that process then is perpetuated.
So they kind of meet together at the perfect timing and keep going.
Right.
Awesome.
Perfect.
Thank you.
Or imperfect, however you want to look at it.
That's true. Good point. Yeah. All right. Thank you. All right. So Susan, I was going to ask you to kind of take us through one of the baseline EKGs here, just kind of simple, just a picture of, anything that jumps out to you. This is one of her first EKGs that she got when she came to our hospital.
Yeah. So I guess I'll just talk a little bit about like my sort of quick and dirty way of assessing the QT, if you're on call or don't have a lot of time. So, what I guess the first step is I never would trust the computer's assessment of the QT. So whatever the number is at the top of the page, just throw it out. I feel like the computer can oftentimes misinterpret, where the end of the T wave is, or, interpret a U wave as part of the T wave or whatever. I just never trust the number at the top. So I always would do this manually whenever there was a question. So I would typically take my calipers and you want to measure from the start of the Q wave to the end of the T wave. And sometimes the end of the T wave can be a little bit hard to figure out. So look for the lead where it's the clearest to you. And you also want to make sure that you're looking at the lead where the QT actually looks the longest. You want to take your longest measurement as your true QT. So it may take measuring in a few different places and a couple of different leads to kind of come up with what you think is the most accurate, i.e. the longest one that you can find. And then, I would never really trust my math in when I've been awake for 24 or 30 hours. So I always just use MD Calc to calculate the QTC, which takes into account the heart rate and sort of normalizes your findings for, it sort of estimates what that person's QT would be if their heart rate were 60. So I would usually measure it myself and then punch those findings into the MD Calc calculator. And I think that one uses the BASIT formula, which again, just sort of adjusts for heart rate. And then the other sort of like rule of thumb that you may hear is that the QT should be less than half of the RR interval. That doesn't always hold up though, because like if you look at this ECG, her QT we know is long, but on this ECG, it sort of does look like it's actually less than half of the RR interval in a lot of different places. So I would be careful about sort of relying on that and rely more on your actual measurement of it and using that MD Calc calculator. Dr. Tong, I don't know if you have anything to add to that in terms of assessing this on your own.
No, I think that's exactly right, that it's better to calculate it, excuse me, yourself, and that, you can be fooled in situations like this if you look at this tracing, because on first glance, it doesn't look like it's grossly more than 50% of the heart rate. So, And the other, to your point about actually calculating it, is, we do correct for things like heart rate, but you really do want to know if the absolute value of the QT interval is grossly abnormal, right? And I think you're going to touch on cutoffs shortly. So,
Mhm. Well, that was a great segue because I was about to ask you about that anyways. So in terms of,
Actually,
thank
just
you for that.
quick
Yeah,
point.
please.
So there, I know there's a couple of other calculators online, but there's one that was just recently published out of Mayo, because of the whole controversy with hydroxychloroquine and COVID. Is something called covidqtc.com, and it's from Mayo Clinic and published by Mike Ackerman, who's actually a very prominent genetic cardiologist, but essentially gives you the QTC calculator. It just basically you can choose any type of basically formula, but also pick, whether you're in atrial fibrillation, whether you have wide QRS, whether you're paced, whether you're not. So actually a really convenient calculator. So if anyone wants to kind of just try it out and use it and see how you guys like it, it's pretty comprehensive.
And I
Oh, that
think
sounds
actually
awesome.
MD Calc has now included that in their calculation as well, because it asks you if the patient
have
has
they?
COVID-19, and then
Oh, nice.
oh,
like uses different logic if they do. So
Yeah, they become very sophisticated. So I would highly encourage to actually do it yourself first, but then also just go back to the calculators and see if you can kind of confirm your findings.
Yeah, that's awesome. You said covidqtc.com.
Yep.
Right? Cool. Cool. Yeah, I'm definitely a culprit of using the kind of gestalt of the less than half of the hour interval, like when I'm just looking at it. So this is a good reminder to calculate it myself too, for especially in these cases where there's any question about this, like we're talking about. And I guess, to the crowd out here, in terms of cutoffs for, the QTC for men and women and how that might be different, what is a number that you feel like is at the point that you're worried about prolonged QTC? And then, based off of that too, which number pushes you to say, I don't want to start any QTC prolonging medications for this patient?
yeah, it's a great question. It comes up all the time in practice. I think that the standard cutoffs that are, promoted are 460 to 470 for men and 480 for women. In terms of my practice, and I think for most people, 500, is really the point where we would be very hesitant about starting any QT prolonging medications. I think if it depends on the clinical scenario, but if they are on a QT prolonging medication that has that's deemed necessary, and their QTC has been stably prolonged between, let's say, 480 and 500, I think that's generally, we might follow them very closely, talk to them about electrolyte abnormalities and trying to avoid them. One common example is for our patients on dofetilide, we'll talk to them in advance about situations that might arise where their electrolytes might become, disarrayed, and to certainly watch out for that, and then be aware of additional QT prolonging medications.
Awesome. Thanks. Yeah, I've definitely used kind of the 500 as a cutoff too. And I think this case is a great reminder too about thinking about what medications they were already on and then adding one more medication that could further prolong it with this Zofran.
Right.
All right. So, Dr. Chang, I have a number of EKGs here from this patient's case from, this presentation. And so I was hoping you can kind of just highlight, your thoughts when you glance at this kind of big picture here at this first EKG.
Sure. So, the first thing that I think, and a lot of this is in retrospect too, but when you look, you can see that the QT interval is quite prolonged. And I would say the things to highlight on this tracing are there's a lot going on, right? There's a lot of non-uniformity on this EKG, whereas I think when we're learning to read ECGs, we like consistent patterns. But what you first notice is that there are all these ectopic beats. And most of the sinus beats are followed by, you see this sort of, you can use maybe your pointer, but are followed closely by an ectopic beat. And then towards the middle to right side of the tracing, there's actually 2 ectopic beats in sequence, right? And so we'll get back to that in a second about how that's a setup for short, long, short, and reentry and torsade. But if you look at, let's say, V3, I think is probably the clearest lead. It's not the most typical lead for looking at QT, but in this tracing, if you move your mouse to the right a little bit, right there. So if you look at that bead, you can see that the QT is quite prolonged. It's not all that apparent where the ECG markings are, but you know, it looks like it probably borders on 600 milliseconds or 3 large boxes. And then just after completion of the T wave is sort of this other small amplitude curve that, as Susan mentioned, it could be a U wave, it could be just sort of, again, part of the T wave continuing, or it just sort of blends into the ectopic beat. So the QT here is very prolonged and there's frequent ectopy. And I think just to add to the history, in going back through the records after she was admitted, it seemed that part of their thinking with starting amiodarone was to suppress some of these ectopic beats that they had seen when she was admitted at the other hospital.
Okay, that makes a lot of sense. And I totally agree. I feel like as, you know, as a second year resident here, I still definitely like, you know, nice clean EKGs where I can see. So seeing this here, it's kind of like, ooh, that's a lot of stuff going on, a lot of ectopy and kind of just systolic badness is what I would say.
Right.
Yeah.
Right. So I think just, you know, to Susan's point, if you just kind of carefully look through the leads and figure out first which beats are sinus and which are the ectopic beats, and then compare the QT interval on the sinus beats to, you know, see where it's the longest and the clearest.
Mm-hmm. Great. All right. So here is, you know, another EKG from her case, you know, I think a little bit later on in her course.
So again, you can see, just looking in this tracing, if you look at this first clear sinus beat in lead 2, you can see that her QT is, again, it looks like bordering on 600 or so. And that looks consistent in some of the other leads. And she has these frequent ectopic beats. And then where you have highlighted just before that, right, you have kind of a short, they're all ectopic beats, but following the sinus, you have short interval, slightly longer interval, a very long interval, and then more ectopy, which sets off a salvo of torsade de pointe or polymorphic ventricular tachycardia.
Mm-hmm. Yeah, and I actually looked up what salvo meant because I had heard that term because I never really knew the definition of it. But it's this sudden, vigorous, or like aggressive act is what is. I'm sure that you guys all know the definition of, but I had never really heard that, and I thought that was such a kind of a cool term of these, you know, short bursts of things that we see before, you know, actually continuing in.
And yes, and this is actually really typical. You will see this on telemetry where there seems like initially there's just individual PVCs, and then there's something a little longer, and then something like this, and then sustained polymorphic VT.
All right, great. So that was a great segue into our next tracing here. So if we wouldn't mind kind of going through this transition into what we see, this sustained polymorphic VT as well here.
Sure. So I'm just looking at the tracing. So as you mentioned at the top, she's having, you know, a triplet there on the first row and then continued PVCs. She has a brief salvo in the second middle strip. And then assume these are continuous. When you look at the third strip on the bottom, she has, as we talked about earlier, a short, long, short sequence, which sets up sustained polymorphic VT. And this in particular, we would call torsade de pointe because it is both morphologically consistent with changing axis and variability in how it appears, but also in terms of the way it begins with a short, long, short, and in the setting of a prolonged QT.
That's so cool about how you're saying that you feel like, you know, or all of this stuff kind of, you have to think about how it starts, like what's the beginning of it, instead of kind of this resultant kind of rhythm. And that's how you make, how these definitions kind of come to be, which is something I didn't really understand fully before.
Yeah, I think that's actually a really important point, is that Torsades de Pointes is a subset of polymorphic VT, and it
Mhm.
implies the mechanism that we talked about with short, long, short sequences setting up probably localized reentry in the setting of a long QT and prolonged repolarization.
Awesome. Thanks so much for going through all of that. And then here's kind of one of the last rhythm strips that we have for this patient's case. If you don't mind kind of finishing off with this one as well. Thank you.
Sure. So this is, sustained. This is polymorphic VT and terminated by a shock. And you see afterwards that the QT segment is grossly abnormal to the right. And then even when her sinus rate returns on the bottom strip, the QT remains, close to 600, maybe 560 milliseconds.
Yeah, this rhythm strip down here is quite striking in terms of the length of QT for seeing that right after the shock.
Yeah.
All right. Okay, so thanks for going through all those strips with us and reviewing that. I just want to take a second here and talk a couple about some risk factors and going through some treatment options for, Torsades de Pointes. So in terms of the risk factors, I feel like, the big things, as we mentioned, are these medications. We already discussed a couple of them that, are very common that we see in the hospital setting. And I just want to make another plug for a reminder of looking at the patient's, medication list, because, before people coming into the hospital, taking their home medication, and then we're doing an additive effect if we're giving them any further QTC prolonging medications as well. Some other things, of course, as we mentioned too, the electrolytes, specifically hypokalemia, hypomagnesemia, as well as hypocalcemia were ones that I found that were very, were more likely to cause, a prolonged QTC, and as mentioned and reviewed by the cardiac myocyte action potential, all of those are involved in this in the action potential as well. And then of course the genetic factors here, and Dr. Tahir is going to take us through some of those risk factors as well as kind of when to think about those. And then another one just mentioned is a slow heart rate, as a further risk factor. And I think, correct me if I'm wrong to the experts here, but it sounds like, this just kind of sets up a further or a longer time where it gives us more time to have a, early after depolarization and set up this kind of short, long, shorter R on T phenomenon in terms of that bradycardia. Is that how you would also think about it, Dr. Tong or Dr. Tahir?
Right. I think so. Baseline heart rate affects, QT and repolarization. And so to the degree that you can avoid bradycardia, you decrease, right? You make it just that much harder, I think, to initiate Torsades.
Mm-hmm. And then something that I definitely did not know about, but female sex was actually a risk factor for, having Torsades de Pointes too. And I guess it's something that has to do with how estrogen may actually prolong your QTC further. Is that, I see some nodding. Okay.
I think
yeah.
I have more to add here, but
yeah.
yes, I think I'm not familiar. I'm not certain we know much more than that about why females have a higher risk for Torsades, but clinically you certainly see that.
All right, great. And in terms of treatments, I feel like I want to just highlight and keep it, kind of simple in how we can think about it. But I feel like the first thing that we always have to remember to do is just try to, correct their electrolytes and avoid the medications that we feel like are the culprits in these cases. I think that's, one of the things that we can really try to, harp on. And like you said, some patients really need to be on some of these medications, and we have to just kind of make that balance and do our best to prevent an episode of Torsades in that case. And then in terms of the acute setting, IV magnesium is the kind of first line treatment for these patients. And I was hoping that we could kind of just look through a little bit in terms of the mechanism here. And I have a figure there. Dr. Chung, can you kind of speak to that as well?
Sure. So magnesium, as you said, is used, IV magnesium, as the acute treatment for Torsades. And magnesium inhibits the L-type calcium channel, right, as you have indicated there. And so, as we were saying before, if the plateau phase is a balance between calcium and magnesium flux, then you can imagine that inhibiting that would be helpful, right, to making the repolarization more, bringing it in the more normal direction.
Mm-hmm. Yeah, and I think that's awesome because that's not something that, I'd always known magnesium, but I really didn't understand as to why that was, the targeted treatment, and thinking it as kind of like the body's calcium channel blocker in that sense too. It was a helpful way for me to remember that at least.
Can I ask a quick question about that, actually? This seems like maybe an obvious question that I should know the answer to, but why not then just use a calcium channel blocker? Is it that you don't want the heart rate slowing effect, or is it a mechanism like that magnesium is faster onset?
I think both the fact that it's, rapid onset when it's used IV, but also that you don't want the heart rate slowing effect.
Right.
There's also magnesium has an action as kind of a cofactor in the sodium potassium ATPase. So I think the primary mechanism is via the calcium channel inhibition on the myocyte, but I think it has additional properties that help it in a way that a calcium channel blocker alone does not. The one thing I would add in terms of your risk factors here is heart failure, and in some cases LVH. And the mechanism for heart failure being a risk factor may very well be through electrolyte disarray. If you think about how these patients either have been getting at home or will be getting a lot of diuretics. And that is, one of the main drivers of hypokalemia, hypomagnesemia.
Awesome, thank you. And the last part of the kind of the treatment things that I want to talk about, and you just kind of mentioned it as well, about worrying about, slowing down the heart rate. One of the treatments for these patients is actually speeding it up. And I wanted to ask, when would we start thinking about, using either pacing or isoproterenol to help these patients? I haven't really seen that before.
Yeah, so this is something that we reach for quite a bit if we want to kind of address the effects of either overcoming drug effects. Let's say they were taking a lot of beta blocker or calcium channel blocker, and we're waiting for that to wear off. You could reach for something like isoprel, and we do this occasionally as kind of a non-invasive way to speed the heart rate up before you have to do something like a temporary pacing wire. So that you may see when you're rotating through the ICU.
And do you tend to typically wait until, like if somebody has had one episode and they're shocked out of it, do you wait until they're having recurrent salvos to kind of pull the trigger on doing this? Or is it a QT length dependent thing? Like if it's really long and you're worried that you're just not going to be able to shorten it any other way? Like what clinical features? Yeah.
Yeah, I think it depends on the heart rate, right? Because if they're pretty long and they're not that slow, I feel like that's a harder one, right? Because then you're mostly left with electrolyte correction and magnesium. But certainly if their heart rate is very slow, that's easily correctable. So that's typically when we would think about isoproterenol.
And then based on that too, Susan, you asked kind of in terms of the length, a lot of these, I feel like, break on their own, right? They actually are able to get out of this kind of reentrance circuit on their own. Is that something you often see in practice, or do you feel like, these patients do need the IV magnesium, often when we're seeing them in the hospital at this point?
Was that for Susan? Or
sorry, either or. I just, sorry.
You can take that one. Go ahead.
Sorry.
You do sometimes see salvos alone that don't progress, but I would say that's much rarer. In general, I think if they have the ingredients, so to speak, for Torsades, it tends to sustain until you intervene.
Okay, awesome, thanks. All right, great. That was a great review. All right, Dr. Tahir, I was hoping that you'd be able to, talk with us a little about, when we should be thinking about genetics and what are the kind of the common things that we are seeing on these genetic panels as well.
Yeah, sure. So, just stepping back, taking a look at long QT in general, like any diagnosis, the first thing is history and physical, and making sure that you've taken an accurate family history as well is going to be incredibly key. And what I mean by that is, when you're asking about family history, it's really this: has anyone had a sudden cardiac death or any arrhythmias? But oftentimes people will say, oh yeah, my grandfather passed away of an MI, when he was like 50 or so. And at that point, you just want to really make sure that what actually was it an MI, or was it something that they actually diagnosed as an MI and he came in and he had elevated troponins and whatnot, or is it just he had a sudden cardiac death? And that's one of the points where people start thinking about, well, I actually don't know what they actually died of. And I think that points to something else that's going on besides, coronary blockage. Any unexplained deaths in the family, anyone died at the wheel without really an explanation, all kind of point to possible arrhythmic focus in the family. So again, taking a really close family history, I think, really does do wonders in terms of just picking up on anything. And then obviously their own history. Have they ever syncopized before? Had this, anything like this ever happen from that standpoint? Then when you kind of move on from that, in terms of when you're thinking about long QT, you're obviously looking at the electrocardiogram, and that's right in front of you. And so there are some correlates for long QT, aside from just having a long QT, notch and biphasic T waves. T wave alternans can also be a sign. For instance, in long QT1, you get a little bit more of a broad-based T wave, and in long QT2, there's a little bit of a later onset T wave inflection point. But overall, those are sometimes non-specific, but I would kind of just focus a little bit more on the history, and then anything that you can pick up from the EKG that would kind of point towards a more of a congenital picture. There's something called a Schwartz score, which is essentially, a lot of these long QT episodes are congenital. And so the Schwartz score helps us really figure out what's the likelihood of it is being a pathogenic mutation that's causing long QT syndrome. And some of the features of the Schwartz score include, we talked about this before, but T-wave alternans, the resting heart rate, how long the QT is, if there was any syncope in the family history and whatnot. So an overall score of about 3.5 or more, you're more than 80% likely to actually carry a pathogenic mutation. So actually it's been validated a couple of times, and does really well in terms of figuring out who would actually have a congenital focus for their long QT. So I think I typically like to look at that a little bit more in terms of just figuring out what the likelihood is of actually having a genetic basis. And then in terms of long QT itself, just a couple more things. We always like to do genotype phenotype correlation. So most of the time these are long QT 1, 2, and 3, and then you have the mutations up there. The genes that are most likely involved is KCNQ1, KCNH2, and SCN5A make up LQTS1, 2, and 3, and these actually account for more than 80% of the cases. So you're most likely going to be dealing with those if you ever deal with this during the course of your training. And there are some correlates in terms of history and what the mutation is. So typically we're taught that in LQTS1 with KCNQ1, you're more likely to have an event while exercising, and the prototypical board question is a 12-year-old that drowned and passed away, and that kind of points to more of an LQTS1 type picture. And then LQTS2 is more sudden auditory stimulation or sudden sympathetic drive that might be causing it. And so I think differentiating them is a little bit important in the sense that it does talk a little bit about prognosis as well. LQTS2 and 3 have a little bit worse prognosis than LQTS1, and then beta blockers really help out in LQTS1. And then they do help out for all of them, but especially for LQTS1, they're much more effective. And then finally, in terms of thinking about how to differentiate, how to pick something up, a lot of these patients end up going for stress tests, ECG stress tests, and in particular for LQTS1, you're more likely to find that during recovery phase, you'll get a more prolonged QTC. And so that's one of the telltale signs of LQTS1. So again, all these all of these signs and symptoms and whatnot come into play when you're evaluating the patient. So I think overall, I think sticking with the short score and just trying to figure out what the likelihood is of actually carrying a pathogenic mutation is a great first way to kind of approach a patient who might have long QT. And then specifically for this patient, this patient obviously had a lot of factors going into it, especially for drug-induced long QT. What's interesting is that studies have found that between anywhere from 30 to 50% of individuals who do have a drug-induced long QT actually have a genetic basis for it. And so I kind of think about this as, it's a stress test for the heart or a stress test for your channels, essentially. You're basically putting yourself in a stage where, you have a provoking event and there might be a two-hit hypothesis where you have that genetic substrate and then something else comes in and you have an LPPS event. And so, overall, what the likelihood is of someone who has a drug-induced long QT, some of the things you want to look at are, how long is the QT? Really, really long QT intervals, point to more of, congenital focus. And then, did they have an event? Did they have an actual arrhythmic event? That also points to a congenital focus as well. And so I think, especially in this case, this was, individual had a really long QT interval, had an event of torsades, and I think so. Thinking that this patient would actually have a genetic focus would definitely be the right way to kind of approach it. And then finally, the last thing I'll mention, and this is something that's kind of, we're pointing to the future here, but not everyone who has genetic QTC, long QTC, has one mutation. And so a lot more, we're seeing cardiovascular disease, there's a polygenic focus for diseases, for coronary artery disease, now for QTC. So there might be that you might not pick up anything on these genetic panels, but that doesn't mean that it's not inherited. That just means that there might be multiple mutations, especially in genes that we haven't tested yet for, that might be contributing to it. So never tell a patient if they're negative for a genetic panel, that they don't have a genetic basis for disease. It's one, either we haven't found it yet, or two, there might be a polygenic nature where there's multiple mutations in genes we haven't really studied yet that might be contributing to it. So that's kind of how I approach, thinking about the patient in front of you, what the correlates might be for LQTS 1, 2, and 3, what the testing might show, and then specifically for drug-induced long QT, what the likelihood is of actually being a pathogenic mutation that might be underlying that.
That was awesome. Thank you. And you answered a lot of my questions I had too. I was going to ask about that, susceptibility to a drug-induced long QT. And it sounds like you said like up to 30 to 50%, you said could have that as well, which makes a lot of sense because there's so many people that are on these medications that don't have issues either. So that's something I was wondering about, in terms of that susceptibility too.
Yeah, absolutely. I think that's one of those things where, a lot of people do fine. And if you don't do fine, there needs to be a reason, right? And so we got to look for it. And so I think that's exactly what the team did in this case.
Yeah, and then in terms of those, you said in terms of the polygenic mutations, and these people have a lot of different reasons, and maybe the ones we just haven't found yet. Do we have like I know obviously you're seeing in the clinic, but are we kind of keeping these people kind of on, are we finding new mutations and we're going to rescreen them? Do they have a registry type thing, or how does that work?
Yeah, I mean, so we just started this genetics program this August, and so what we do, and Patty's been involved with a few patients as well. We keep track of all our variants, and so whatever variants that we get within a genetic test, we keep track of them and we follow them over time to see if anyone else around the nation or around the world really develops those kind of conditions along with those variants. And there are definitely long QT registries out there, and we'll be participating in some of these registries going forward. So I think genetics is a pretty even though genetics has been around for a while, the idea that this can be clinically applicable and in clinical practice has only really been the case for the past 10 years, and that's because just the technology that's really brought it to the forefront. And so I think as we get more cases, as we're able to collect more information, as we're able to participate in some of these long-term registries, we'll be able to utilize this information a little bit better.
Awesome. And how do you counsel, this patient in terms of like her children for getting tested? How do you do that?
Yeah, I think sorry. I won't reveal what happened in this case, but
It's coming up soon.
you
So
know, if they have a mutation, then I think it's pretty clear that I would offer that genetic mutation to their children. But even if they don't have a mutation, again, we talked about this, right? So not everyone's going to have a positive mutation, and this might be, and that doesn't mean that it's not inherited, or they might not be at risk from a genetic standpoint. So what I like to say for anyone is, genetic testing doesn't replace clinical screening. So I would actually recommend that the children of this patient at least have their kids evaluated just with the routine EKG, just to make sure that they are also taken care of, followed longitudinally. So again, just because someone has either a positive or negative doesn't replace the fact that clinically you just should be evaluating these patients.
that's great. Yeah. So at least the first step with the EKG, that makes a lot of
Absolutely.
sense.
Yeah.
Awesome. Thank you. So now we'll review what happened in our case. But as I mentioned, stop the like when the patient first got there, we stopped the amiodarone, we stopped all other QTC prolonging medications throughout her hospitalization stay, monitored her with serial ECGs and on telemetry, and she was actually started on Nadolol prior to discharge from the hospital. Just a little bit about the Nadolol. I feel like it's something that it sounds like the idea is, of course, to kind of suppress, ectopic beats and other kind of sympathetic drive. But how do you balance that with not slowing down the heart rate too much? Dr. Tahir, Dr. Tung, hopefully you can both kind of comment on that.
I'll let you kind of take the first crack at that, I guess.
Yeah. So in terms of, it's a great question. So, the reason for starting, typically Nadolol in these patients is based on, and I think Dr. Tahir, I'm sure we'll go into this in more detail, a relatively small group of patients who were studied, and they looked at both selective and non-selective beta blockers and looked at events. And as he alluded to earlier, it seems like the greatest benefit happens in long QT1 patients, but there is benefit to beta blockade in long QT2 and 3 as well. Initially, it seemed like the non-selective beta blockers, were preferable to things like metoprolol and others that were looked at in terms of selective beta blockade. This, and again, I'll punt this to you, Usman, but there is a registry that came out that was slightly contradictory to that, but my understanding is that when they went back and subdivided by QT type, so long QT type, they found that actually the results were not so contradictory to prior, and that in fact the non-selective beta blockers are more effective than the selective beta blockers. And I think that particularly in the case of Nadolol, the beta blockade effects on an ion channel level outweigh the heart rate depression with these drugs, and certainly we see that clinically.
Yeah, and just like Patty said, essentially, these are non-selective beta blockers, and this literature initially really came out of the genetic patients who actually had LQTS1, 2, and 3, and there was clear evidence, that essentially Nadolol and propranolol actually are a little bit better than using metoprolol, and I think some of that was they're just a little bit better at blocking the sympathetic drive than metoprolol would be. And I think a lot of this was the events that are happening in these patients were from overstimulation of that sympathetic drive. And so Nadolol was thought to be and had been proven to be really effective for that. And there's a little bit more literature recently that maybe, it's okay to use metoprolol, but I think for the standard of care really still has been the use of Nadolol overall for patients who have long QT. I think a large part of that is really the theory and the practice of the fact that you're able to better inhibit or blunt the sympathetic drive that is causing a lot of the further downstream arrhythmic events.
Awesome. Thanks so much for going through that. And it sounds like you said to kind of think about more sympathetic as well as more of the ion channel level rather than so much of the heart rate. Awesome.
Absolutely. I think that definitely overall does outweigh the effects on the heart rate.
Great. All right. So then, this patient was discharged from the hospital. She was doing well. She was discharged with an event monitor for a couple of weeks. That was all negative. And then she did get genetic testing and actually saw both of our experts here on the panel and, followed up with Dr. Chong in clinic. And in terms of kind of follow-up, any changes or anything else kind of going from the plan? I know I revealed that her genetic testing was negative. Did you counsel her on having her children get some EKGs and following up and things like that?
We
Yeah,
did.
absolutely.
Oh, go
Sorry, go ahead.
Yeah, no, please.
No, I think just like we mentioned before, I think the key thing is even though it's negative, always tell patients that from what we've tested so far in terms of monogenic disease, you don't have anything that kind of popped up. It doesn't mean that you don't have genetic kind of contributions to your disease process, and just to make sure that at least your immediate family members are just clinically screened initially and kind of followed up over time, I think is really the best we can do. It's really unsettling when you don't find an answer. And that doesn't mean we won't find an answer 10 years from now. I think that's one of the reasons why we're studying these diseases. But for now, I think nothing replaces clinical screening.
Yeah, and I think something that I'm going to definitely take away from this case too is what you mentioned in terms of kind of counseling about situations that these patients might get into where they could lose electrolytes or have, just things in the outpatient setting that you can counsel them on before they leave the hospital or if you're in clinic as well. That's really helpful and a good advice going forward for any clinician that's seeing these patients in the hospital too.
Yeah,
Awesome.
I think there's also a website. I forget the name of it. Is it something crediblemmeds.org or something like that, where the patients can kind of go and look at all the possible prolonged. I mean, it's kind of unsettling when you see how many drugs actually cause prolonged QT, but it's just nice for the patients to have, just so that they can actually just make sure that if they had an event like her, or someone like in the situation, that they can kind of be informed about their condition.
Yeah.
Yeah, that's great. And yeah, definitely in terms of kind of I totally agree. It's a little unsettling where almost every single medication can prolong the QT, it seems like, but it's good to know the common ones and go from there. All right. So I just want to go over some take-home points from this case. So we talked about polymorphic ventricular tachycardia, either the QTC being prolonged, like in Torsades de Pointes, or not. We talked about, really wanted to emphasize checking the medication list. Don't forget about any pain medications and how that can be in additive effect. The more medications that could be prolonging to QT can, work together to further prolong them and create this kind of bad situation. And in terms of treatment plan, including a few simple steps, stopping these QTC prolonging medications, and then using IV magnesium and potentially speeding up the heart rate in the acute setting. And then last but not least, think about long QT syndrome, think about when this could be congenital syndrome, and make sure you're taking a really good history in that setting as well. Awesome. All right. Well, thank you so much to everybody for being on this ZollCenter episode. I really appreciate you guys being here, and thanks so much for the great discussion.
Thank you.
Thanks.
Thank you so much.